in public. So as moving ahead, this webinar is hosted by Management Sciences for Health and the Joint Learning Network. So MSH, briefly, is over 50 years, the management scientists for health worked in 30 countries at a given point of time, and has been at the forefront of strengthening healthcare systems across the globe. As trusted partners to government, health organizations, and private sector, MSH provides expertise in health financing, infectious disease, strengthening pharmaceutical systems, digital health, and overall health system strengthening. We have a registered India body, which is registered as a for-profit entity and has been working closely with Government of India and global health organizations to implement innovative healthcare solutions. Currently, we are actively engaged in programs like health systems for TB and are experts in outcome-based financing models, digital health innovations, and public health management. Joint Learning Network, JLN, is a unique country-driven platform that has pioneered facilitation of cross-country learnings and collective problem-solving approaches for health system strengthening. At the core of JLN approach is its ability to engage country policymakers and practitioners from across the globe to collaborate and address common health system challenges by bridging the gap between theory and practice, enabling a co-development of practical solutions adaptable to country-specific contexts. Now, as we move ahead with the session, this just a few pointers in the beginning. This whole session and the webinar will be recorded in English only and will be shared with the participants along with a blog. We are planning to have a blog at the end of the webinar, which will be shared with all the registered participants. The ground rules are, some of it is, please remain muted through the webinar and only speak when requested during the presentation. Feel free to share any questions in the chat and we will take them along in between the speakers, and there will be a longer session at the end of the presentation. We'll take questions as the first two speakers finish their presentation. We will have a brief discussion. And as I mentioned, there will be a longer Q&A session at the end of the presentations, at the almost after 60 minutes of the webinar. And we have kept almost 20 minutes for the Q&A session. So the agenda, can we have the agenda slide, please? So the agenda, as we speak, there is an opening remarks by Professor General, Major General Dr. Kotwal, who is with the Ministry of Health, NHSRC. He's running a bit late, but as soon as he joins, he will provide his opening remarks, followed by South Asian perspective on urban healthcare, which will be presented by Dr. Somil Nagpal from lead health specialist, global practice on health and nutrition and population, East Asia and Pacific region, World Bank, from World Bank. Then we'll have a quick round of Q&A for 10 minutes. Post that, there will be a presentation on Malaysian experiences in urban health by Dr. Dinesh, who is a Senior Assistant Principal Director, Health Transformation Office at the Government of Malaysia. Following that, we will have a presentation on leadership and governance by Dr. Madan Gopal, who is advisor with Public Health Administration, again, Ministry of Health, India, and a quick Q&A. And at the last, but not the least, is the presentation by Mr. Ashad Islam on Bangladesh experiences in urban health. He is a Chief Technical Advisor at Health Economics Unit of Ministry of Health, Bangladesh. And then post that, we will have a Q&A with the audience, and following closing remarks and wrap up by myself. So this is how it has been laid out. It seems Dr. Kotwal is
here.
Okay.
Yeah, I'm very much here, Dr. Anupama. Good evening, everyone.
Okay, that's great. So can we have, so I'll take the opportunity and the honor to introduce Dr. Kotwal. Dr. Kotwal, as we say, Major General Dr. Professor Kotwal is a public health specialist and epidemiologist with 40 years of experience as medical professional, researcher and administrator, educator, mentor, and teacher with significant contributions in the field of public health. His area of expertise largely include health systems, planning and implementation of healthcare policies, primary healthcare, urban health, epidemiology, HTA, health technology assessment, implementation research, and interdisciplinary research. He has received his MBBS, followed by MD in preventive and social medicine from Armed Forces Medical College, and he holds postdoctoral fellowship in epidemiology from the Clinical Epidemiology Unit at All India Institute of Medical Sciences and the Center of Social Medicine and Community Health at the Jawaharlal Nehru University, New Delhi. He has extensive experience, including his service in the armed forces, working at the international level as advisor to the government of Botswana, and providing technical support to Government of India as OSD in Public Health Planning Commission, where he was involved in planning and finalizing 11th five-year plan, reviewing NRHM, National Rural Health Mission, as we call it. Now we call it as National Health Mission, and conceptualizing urban health. He has also greatly contributed in the formulation of several policies and guidelines at the national level. So quite extensive experience in the policy, and he has been quite influential in driving various national health programs at India, and also leading one of the think tank in India, policy arm of the Ministry of Health. So over to you, Dr. Kotwal, to just brief us on the different aspects of urban health and what are the issues related to out-of-pocket and all, and just open the webinar. Over to you, Dr. Kotwal.
Thank you, Dr. Anupama, for that introduction. Thanks a lot. I hope I am clearly audible. I'm sitting in my car. I just left a meeting which was ongoing in Nirman Bhavan. We had a review of UP which started at 11 in the morning and it's still ongoing. So I left at 10 to 6. I think it'll finish only by 7 or maybe after that. So we have the midterm review where the state proposals are discussed and all. It's a PAP process, which is a strength of National Health Mission. So coming back to this webinar today, and thank you very much to the MSH team, Dr. Anupama, especially for organizing this. And the universal health coverage, I think we all the experts which are here are already aware, but then all those who have joined online, who are in the listening mode as such, the National Commission of Macroeconomics and Health, which followed the International Commission of the same name at the turn of the century, I think that's the one which was a major one of the major factors, and also the government's viewpoint that from 15% in public health sector, which was the 1990s, and the user charges and all, something needed to be done so that more and more people start using the public health facilities, and the NRHM came into being, which has been a major game changer. It was supposed to be only for 7 years, but then that's something I think I look forward to the experts' comments also that NH and as well NRHM, now NHM, after subsuming the National Urban Health Mission also. It was supposed to strengthen the system and be there for 7 years or maybe some more years particularly, but it has now become the system as such. So how to proceed ahead, that also needs to be discussed towards the end of this webinar. Rural health, a lot of changes have taken place, and now with the Ayushman Arogya Mandirs, the as well health and wellness centers, which was launched 2018, based on the recommendation of National Policy 2017. There's a major 9-point reform, as we call, and one of the most important being the additional HR of community health officer. with the increased and diagnostics and drugs under free diagnostics and free drug services initiative. There's enhanced funding under the NHM as such, and also PM Abhim and 15th Finance Commission, Ayushman Bharat Health Infrastructure Mission and 15th Finance Commission tight grants of health. There's a funding now available for the infrastructure, for diagnostics, and also for the surveillance and all, and the labs and integrated public health labs, block public health units, and the from the central sector of PMAB, the strengthening of the NCDC with various zonal NCDC labs and NIVs, 5 zonal labs, and integrated health information portal, strengthening of our ports, 15 number. So all that is taking place with India's move towards universal health coverage as such. The accessibility, availability, affordability, equity, safe and quality services. So we have national quality assurance standards where we are trying to certify every facility now at as per the standards. We have Indian public health standards which we revised in 2022. It was first time launched in 2007, then 2012 revision, and 2022 NHSRC was the main driver, and Dr. Madan Gopal would be, I think, joining shortly. He's still I think sitting in that meeting, and PHA division of NHSRC along with other divisions were the major driver of the revision of public health standards. So we have defined standards now for each and every health facility. So coming to the urban area, a new structure has been proposed under the Abhim and Finance Commission guidelines, and funding is being given to states to create urban sub-centers or urban arm as such, which is below the urban PHC level. PHC is at the population norms of 50,000, one PHC per UPHC per 50,000 population. We said, okay, let's starting with the disadvantaged areas within the urban areas, especially urban slums and all. Have 2 to 3 urban Ayushman or Mandir urban sub-center level under the UPHC. But here the head of that this facility is going to be medical officer, not the CHO, because CHO are primarily nurses with few Ayush practitioners, which will be trained for 6 months in a bridge course to become the community health officers. But here is a medical officer assisted by a staff nurse and also pharmacist and ancillary staff. That's something which states are now making, and there's the flexibility wherever they need. The numbers were given earlier, but now there's the flexibility as per need to look at the areas which will utilize those facilities more and have linkages with the UPHC. So instead of the outreach of medical officers and specialists and all, it's now we have this kind of facility available in 15-20,000 population as such. The increased number of drugs and diagnostics, which are at the rural areas, same is applicable for the urban area also. Another change which has been done, in urban is that one UPHC out of 4 to 5 can be converted to polyclinic, because urban areas the specialists are available in private sector. We said, okay, you contract in the specialists, and against I think 2,000 odd plus this thing UPHCs, 1,100 have already been converted, out of which we evaluate. It's not evaluation as such, but just a quick short survey as such, and just get some information of 272 of those sometime towards the end of the last year. And there's a huge number of footfalls which have increased because the specialists are available. And many of these specialist polyclinics, as we call them, are providing these specialist services in the evenings and all, where the urban people can utilize those after their working hours. But otherwise, yes, when we talk of the universal health coverage, there's a well-defined, referral pathways and all, not very well utilized. But yes, we are trying that continuum of care as far as rural areas are concerned. There's a well-defined roles and responsibilities of every kind of facility. But here in urban, that kind of definitions are not there. And there's a huge variation amongst the metros as such, and these metros are different from each other. Like Delhi, you can't compare with Mumbai with Mumbai. Bangalore has got its own challenges and own kind of setup. Chennai is entirely different. Kolkata is on a different scale as such. And then we have the cities smaller than these. So we have 3 kind of classification. And for each, there's a lot of work which is required to have tailored kind of, interventions, and also the referral pathways. Like Mumbai, there's a unique thing that olden days they were maternal and child hospitals. So they are trying to strengthen those only. When we visited, we spoke to them that why don't you convert them into hospitals as such at that level. with linkages with the some private, whether NICU and all other facilities. If you don't have, you can always link with the private for what we don't have, but provide all the facilities instead of only maternal and child, which was the erstwhile, like Sunawala, there's one by his name. Similarly, in that area. Similarly, in Pune, which has become also like, with the Pimpri-Chinchwad Municipal Corporation, which has come up now, it's become huge. So each one has its own challenges, and we have somehow, till about a couple of years ago, looked at replicating the rural learnings into the into the urban. That is now changing, and it needs to change. And I think in this webinar, we look forward to listening to the experts that what new approaches can be done. So you all are aware what is being done, but how to make more effective and efficient. I would be looking forward to listening to you all, and to get your views on the how to strengthen it, how to make everything accessible, affordable, and also I think what we forget sometimes in the UHC definitions is acceptable also. So that's why how to involve the community. For we have Jan Arogya Samitis now at the arm level, which in the urban area also in the urban arm and urban PHCs is there. We have Mahila Arogya Samitis in the urban areas. How effective they are, how to make them more effective, how to involve them in the planning process and community needs assessment also. How to make urban ashas as effective and efficient as rural ashas. And so that's these are the things like we said, okay, we have village health sanitation nutrition day and nutrition and committee also. So similar level we have urban health sanitation days and all. But what to exactly do in those and how to make them fully functional, because we have various wards and very different kind of structure, and intersectoral coordination in urban becomes more and more important. In rural, it is there, it is happening, it is easier to do. But again, a lot needs to be done. But in urban areas, it's a huge challenge. So and again, the health, in Bombay, there's another kind of structure. In Delhi is another kind of structure. So to look at some kind of commonality and some variations, but then approaches and all, which we will look forward to, the experts' views. I think I'll stop here because I need to give time to the experts to listen to them for their views on this. Thank you very much for organizing this once again, and look forward to the deliberations in this webinar. Over to you, Dr. Anupam. Thank you.
Thank you, Dr. Kotwal. You raised very pertinent issues and also shared so many important aspects linked to policy and the pressing issues in the urban health. That's what I think the whole of the low middle income countries are facing. Now I'll move on to our next presenter, Dr. Somil. Just giving a brief bio about him, very brief. However, he has a plethora of experience. So Dr. Somil is the lead health specialist and cluster lead for the World Bank Health and Nutrition Programs in Indonesia and Timor-Leste. He has represented the World Bank team in the Joint Learning Network for universal health coverage since its inception. Before joining the World Bank, he worked for the Insurance Regulatory and Development Authority in India, where he established the country's first specialized health insurance regulation unit and led the regulatory and development initiatives for the health insurance sector from 2007 to 2009. As an officer in the Indian Civil Service, he has also served at the Indian Ministry of Health and Family Welfare, the National Commission on Macroeconomics and Health, the World Health Organization, and Ministry of Finance. So over to you, Dr. Somil, to enlighten us on the East Asia's issues pertaining to urban health. Thank you.
Thank you very much, Anupama, and a very warm good evening, good afternoon, good morning, wherever you are. I'm going to present an East Asian Pacific perspective. Next slide, please.
Hello, thank you, Samuel. Thank you, good day.
Hi, Titus. Hi, everyone. So, looking at the EAP countries, as you can see from the UHC service coverage index across the countries in the East Asian Pacific region. There's a long way to go for many EAP countries. Countries in the Pacific in particular have a little lower index. There are, of course, some countries that do very well who are in the darker colors here, and some of the world's highest. So your USC index is also found in this region, but the predominant color in this region is really the lighter shades of blue, given that there's a long way to go. Next slide. One of the major challenges with the service coverage is because of the non-communicable diseases. This is a listing of the status of non-communicable diseases on detection and treatment across the East Asian Pacific region. And as you can see from the very large bars of red, orange, and light green color, and the very small bars of the dark green color, that the cascade of non-communicable diseases is not in the favor of the region. Most conditions remain undiagnosed, but for most people, and in many others, it is diagnosed but not treated, or treated but not controlled. And a very small proportion, relatively, and with Mongolia, with about a quarter of the population doing better, is probably at the highest end of the spectrum here. So there's a very large challenge of health delivery systems being ill-equipped and not being structured to tackle non-communicable diseases at scale. Next slide. Aging is another problem. This region is home to the largest number of aged people, population with age more than 65. This is a distinction as per the World Bank regions, and the East Asian Pacific region with more than 300 million people above 65 is not only the one with the largest number of old people, but it is also aging fast. You can see how quickly the growth is expected to happen on the right side panel. And this is where we will find that there's a challenge of getting old before doing better on the socioeconomic front. And this is going to be a major pressure, particularly on urban areas where family or society support systems are much weaker, and urban areas need to find a way on how to deal with the aging populations that they increasingly will host. Next slide, please. And this slide is from South Asia, and is a very good illustration of how the Asias are experiencing the challenges of urban health. And we can see from this slide that if you look at the upper two panels, you'll find that the national averages on some of the health outcomes may look better for the urban sector. So urban average may look a little better than the national average in some cases, not in all cases. For example, in infant mortality, even the urban average is unfavorable. But even more importantly, the difference between the quintiles is very marked. And the poor in the urban areas consistently do worse than the national and the urban overall average situation. And this gap between quintiles is very large, as you can see, between this green triangle and blue dot on these slides. There's also very concerning incidents of catastrophic health spending. And that's again something that we need to be worried about. And again, the treatment source and acute respiratory infection is an example on this panel with the red and blue graphs. You can see that a lot of the access to care or initial access to care is from the private sector, much more so for the urban areas. And again, the systems are ill-equipped to integrate the private sector, and that's an engagement that needs to deal with a lot more understanding, education, and tools that the system will need to have. So there's a lot of ongoing contextual challenge. Next slide. And in that context, it's just a kind of a summarization of where we stand vis-a-vis some of the potential emerging solutions and innovations that this region is trying to do, and some examples of cities, urban areas that have tried these innovations. So, for example, for the very large challenge, let us say, of mental health, we have programs on mental health awareness, community support, and using technology, both mobile-based or chatbots that can chat and support individuals for mental well-being have been tried in a range of countries. Nutrition obesity as another example, a problem not limited to urban areas, but certainly a big emerging challenge that is also contributing to non-communicable diseases, is being addressed through better education, healthy food, use of health taxes and sugar taxes, for example, better food labeling, promotion of sports and fitness, and even finding ways to do better urban planning that actually encourages people to walk or bike. And a lot of countries in the region have tried to do that better. On traffic and air pollution, trying to use better public transport systems has been an important tool. But other than that, also using smart traffic management, using congestion surcharges, better ride sharing programs, rules of odd even, rules such as only some cars can go on a particular day in certain areas, have been tried in a range of countries. Likewise, better investment in water infrastructure, recycling, and eco-friendly management, trying to expand elderly care services, using telemedicine, using better workforce training, trying to create climate resilient infrastructure, early warning systems, better building standards for reducing climate change, and finally, improved surveillance and vaccination programs, including increasingly for cervical cancer and even non-communicable diseases and adult vaccination. And of course, improved healthcare infrastructure overall are the many things that we see happening across the region. And there's a set of examples here that are being tried. So to summarize, just to say, a big challenge ahead. Urban areas are places where the health system did not have its conventional structure in most countries. The easy access to hospitals has confounded the referrals and gatekeeping system in many cases. Health financing innovations have tried to introduce gatekeeping in some countries and also tried to engage with the private sector. But there's a long way to go. And we are in a situation where some collective thinking around urban health and learning from each other on urban health would be an important step to help resolve these ongoing challenges that countries are facing, and with lots of cross-regional lessons as well between South Asia and East Asia. Let me stop there, and thanks very much, Anupama. Back to you.
Thank you, Somal, for bringing out all the issues concerning urban health and health in general. And it's a huge, it's a very comprehensive subject, but you have presented the points concerning the East Asia. And it was interesting to see the Pacific Islands being coming on top for most of the NCDs, undiagnosed NCDs. That is also one of the emerging areas. And however, we know that in spite of so many initiatives being taken in urban sector as such, urban development and urban planning, but still there are still the issues of disparities, fragmented healthcare deliveries, fragmented disparities between the schemes which are influencing provider payment, epidemiological transition, as you've just mentioned, the aging population. Thailand was supposed to be projected to become an aging society by 2025, and the rising demand of healthcare and the new expectations. So with that, how do you see how to keeping all these challenges specific to urban health? What are the examples we have? One of this, as you mentioned there, just the health specific intervention won't result into better health outcomes. It's the social determinants of health and the other development initiatives which actually affect the health outcomes. So what can you share some of the specific examples specific to cities that have done some innovations on solutions for the challenges generally faced, very specific in an urban setting?
So I think though it is a small country and very special in many respects, Singapore has a lot to educate. It's an urban country in many ways, but the way that they have been able to build their public transport systems and encourage healthy activity while still being able to legislate and regulate areas such as food, the food labeling requirements in the country, the taxes on sugar, the making available areas to exercise and move, putting traffic congestion surcharges to reduce vehicular pollution, and even very expensive licenses to hold a personal vehicle, have all been many ways in which these things are being addressed. Of course, for them also and many others, aging and high level of NCDs are unavoidable. But then investing in health systems, investing in preventive health and better management of cases is important. Many other countries are trying to do better with telemedicine and trying to use technology in a better way to be able to reach out to people to remind them about the need to have more activity or to be able to take their medicines on time or share challenges around movement. And I think many of those nudges are known to be very powerful. The challenge again is that which quintiles are accessing these. And again, many of these interventions may reach the higher quintiles, and the lower quintiles may again have a digital divide in some of these interventions. And so the equity dimension of urban health becomes even more worrisome because some of these advantages and gains are not always available to the lowest quintile. Let me stop there. I hope that answered your question.
Yes, we'll probably have more questions around the poor, the most vulnerable in the urban area, why he or she has the worst health indicators. Now, moving to our next speaker, Dr. Dinesh. Dr. Dinesh is going to bring on perspectives on the urban health and the universal health coverage in Malaysia. So Dr. Dinesh is a senior policymaker and with a permanent role as a transformation office of the Ministry of Health Malaysia, part of the team spreading initiatives focused on the health reform and transformation. As a key member of the core team behind Malaysia Health White Paper on Health Reform, he played an instrumental role in shaping the policy framework that will guide the national health sector reform for the next 15 years. In addition to his pivotal role with the ministry, Dr. Dinesh serves as the co-convener of the Joint Learning Network for Universal Health Coverage, a testament to his commitment to advancing global health agendas. With a demonstrated experience in health systems and financing, he brings invaluable insight to the table, ensuring that Malaysia remains at the forefront of progressive healthcare policies. Prior to his current position, Dr. Dinesh honed his expertise as regulatory pharmacist during his 9-year tenure with the National Pharmaceutical Regulatory Agency. His multifaceted background equips him with a comprehensive understanding of the healthcare landscape, enabling him to navigate complex challenges with a finesse and drive impactful change. We are grateful to have you, Dr. Dinesh. Over to you for the presentation.
Thank you, Anupama. I hope you can hear me well. Okay.
Yes, we can.
Good evening, good afternoon, good morning, everyone. Greetings from Malaysia. It was a good presentation by Somil earlier that alluded how Southeast Asia is faring and doing in its challenges in urban settings as well in achieving UHC earlier on. Let me just, I'll be sharing a short presentation on the topic of UHC as well, but with regards to Malaysia's urban settings. Next slide, please. I'll be focusing today on exploring healthcare in Malaysia urban settings, understanding a little bit of Malaysia's health system, understanding the unique incentives that drive UHC in Malaysia, and also key challenges that's faced in urban healthcare, and also some opportunities for improvement in healthcare delivery in Malaysia. Currently, Malaysia, as you can see, it has a dichotomous dual healthcare system. The government sector providing comprehensive healthcare on the left coexists with the thriving private sector that's on the right. Both functions almost independently of each other, but we have managed to have some sort of collaboration and integration for some certain things that are a little later on. The private sector provides mainly personal healthcare for the individual, and it's usually financed through who has the ability to pay through private health insurance, employer funding, or from out-of-pocket expenses. Whereas the public sector covers both personal and community care, as well as public health, dengue controls, and so on and etc. And everybody has access to the public healthcare system for a nominal fee, and it is also has a safety net in that sense that if someone cannot pay, usually the fees will also, when a poor person comes, the fees will be, they don't have to pay anything in that sense. The public sector is funded mostly by the revenues of the government. In terms of infrastructure, we nearly have about 150 public hospitals, whereas in the private sector, we have about 212 private sector hospitals. But in terms of bed capacity, the public hospital has 2 or 3 times more than the private sector in that sense. In terms of clinics, our health clinics, we have about 3,000 health clinics, but they are quite comprehensive and big health clinics covering from MCH up to NCD treatments and so on and so forth. And on the private side, we have our private general practitioners, which comes about 10,000 GPs, mostly individual clinics or in consortiums, but they are technically individual clinics to a certain extent. But in terms of burden of patients and so on, almost 70% of inpatient admissions are in the public side, in the public sector. Next slide, please. In terms of health expenditure, just a macro look on it. Malaysia spent around 4.6% of GDP in 2023, amounting to about 84 billion ringgit. And this is technically almost half to half to the public sector and private sector. The public sector is about 2.4% of the GDP and 2.2% in the private sector. On the private expenditure, technically, the large portion is through out-of-pocket, which accumulates to about 36% of total expenditure on health. Whereas on the composition of where it is spent on, nearly 27% is on primary healthcare. This is both public and private. Hospital has the highest, whereby it's 53%, both public and private combined together. Next slide, please. Just in terms of the urban population trend, our urban population has grown to about 78.7%. That's nearly 80% of the population who are in the urban areas, from 26.6% just after independence in that sense. This rapid urbanization technically has created opportunities, challenges for healthcare delivery, particularly in ensuring equitable access to quality healthcare services, and as well as the development of infrastructure is also commensurate in Malaysia in terms of the urbanization as well. So a lot of the even public hospitals or public facilities are scattered around most urban and also the rural, whereas the private hospitals and private facilities are more concentrated in the urban area, and you have a high concentration of facilities in the urban area at this point of time, and it is as the data shows, it commensurates with the development of the urbanization. Next slide, please. Okay. Just as I've alluded on the Malaysia healthcare system, just a few key points on the current state of healthcare in urban Malaysia. Malaysia has made significant strides in healthcare provision. Technically, all Malaysians have access to healthcare, at least at the public side. The private sector, of course, if you have the ability to pay insurance and so on. There is a symbiotic dual healthcare system, public and private healthcare. Why did I name it symbiotic? Because anything that affects one sector affects the other sector. For instance, when the cost of medical inflation increases, some may not be able to afford in the private sector, and a lot will fall back to the public sector, and the burden shifts from one to another. So there is a symbiosis between them, even though they're almost independent of each other in that sense. And as I've alluded earlier, urban areas have higher concentration of healthcare facilities. It is as the country has developed into a upper middle income economy, and as more urbanization has happened, and this is common, I think, across the global arena. Rising healthcare costs are particularly noted in private facilities. Our medical inflation is nearly 15%, one of the highest in the region. And higher than a global average in that sense. And also there's an increasing demand for health services from the growing middle class. And as Somil has alluded in the previous presentation, NCD burden is one of the more I would say the interventions need to be placed in addressing NCDs, because our sustainability of financing and so on is also affected through this. Next slide, please. Key incentive for universal health coverage. Malaysia technically has a good economic growth, year on year 5% at this point of time, and we have moved well from the from the COVID in 2019 and 2021. We're making progress. It's creating fiscal space for healthcare expansion, but our tax to GDP ratio in terms of government revenue is 13%, almost 13%. Which is quite low for an upper middle income country. But there is fiscal space in terms of the private financing that we are also looking at harnessing to achieve UHC. Next, strong political commitment is essential for healthcare transformation. Since independence, Malaysia government has been health has been the forefront of agenda in the government. Technically, we received the second largest budget out of the federal budget after education. So it has been an agenda, and even during COVID, the way the government has remobilized funding, resources, and etc. To address the COVID pandemic at that point of time. The growing urban population requires comprehensive coverage solutions. We have to innovate on and evolve as this is evolving through digitalization and etc. And addressing health equity between different income groups. Our urban populations, technically, the larger amount of people are the middle income and the lower income groups. You also have urban poor, technically, in our urban areas, and an aging population as well, which has almost hit about 5% of the urban population. And also there's potential to leverage existing healthcare infrastructure for UHC. Next, please. So some of the challenges I also have alluded earlier: rising costs of urban living impact healthcare affordability significantly. So as medical cost inflation, more could not reach the private healthcare services. So they have a fallback to the public healthcare facilities, and this increases the capacity constraints in the public healthcare facilities with the growing demand. There's a lack of integration, but we have made some progress. We have established a strategic purchaser under the government who technically can purchase from both the public and private, and we have run a few programs, mainly on hospital outsourcing as well as screening. And during the COVID, the strategic purchaser played an important role in rolling out our COVID vaccination, both in the public and private sector at a high speed. Non-communicable diseases are increasing. This is common within the Southeast Asian country, and also I think in the global arena in that sense. And every country is finding a solution that could intervene and in a sustainable manner. Environmental factors, we are not far from any other country. We have pollutions, floods, and etc. in our country. And healthcare access affect the urban poor as well. For instance, some of them, because on the social side, they have to work and earn, and they come late sometimes to get treatment. And you see the undiagnosed proportion from the Somil slides earlier is nearly 30 to 40% in Malaysia. But we are carrying out initiatives in terms of health screening initiative. We have a national health screening initiative that is ongoing. And hopefully this will also be followed up and we can keep our citizens healthy and not go further in their diseases. And sustainable financing is essential for long-term healthcare success. Next, please. There's a few opportunities and solutions that we are looking at. I've summarized this. It's a bit more detailed, but in terms of digital health technologies, Malaysia is moving towards a one patient, one record. Currently, everybody has their own record, even in the public hospitals as well as the private hospitals individually. So we want to make sure records can be shared. And also, this also improves efficiency within the health sector. In that sense, for instance, if you've already done MRI in another hospital, you don't have to do an MRI in another hospital in that sense. So your information is shared and you don't duplicate and so on, and doesn't increase the cost for a patient if they happen to pay out of pocket in that sense or through their insurance. Public-private partnership to expand coverage. We have a great infrastructure, both public and private, a lot of room to leverage on the private sector, as well as innovation in health financing models. So on the point number 2 and number 3, we are looking at ways how do we leverage private financing and private providers towards universal health coverage. We are looking at how do we purchase from private providers. We have already done a few things, as I alluded earlier, and through strategic purchasing, as well as how do we shift the paradigm in the private sector towards a value-based healthcare based on outcomes and etc. And as well as provider payment mechanism reforms for the private sector as well. Lastly, we're also looking at strengthening our primary healthcare networks because we believe community care, primary healthcare is one of the solutions and the bigger intervention to ensure sustainable health financing in the future. Next slide, please. In conclusion, achieving universal health coverage in urban Malaysia requires a balanced and a multifaceted approach. We must effectively leverage existing infrastructure while addressing financial challenges to ensure sustainability. Ensuring equitable access across all urban population and promoting sustainable healthcare delivery models are crucial. Above all, success will depend on commitment, innovation, and collaboration among all stakeholders within the healthcare ecosystem. Next slide, please. Okay, just as I end, I would just like to allude to these powerful quotes from our former Chief Minister and Prime Minister, our first Prime Minister, Tunku Abdul Rahman, in 1955 and 1957. His word remind us that Malaysia's commitment to healthcare isn't new. It's deeply rooted in our national identity. While his focus was on rural health centers in the beginning, as most of our population were in the rural areas, it's deeply rooted in our national identity, as you can see, as Malaysia advanced is in its UHC agenda, prioritizing healthcare and making an energetic countrywide attack against disease even at that point of time, because we had a lot of these communicable diseases going on at that point of time. And it remained relevant today to our work. And it's the next step of evolution in terms of Malaysian healthcare that we need to transform. And as you have alluded in my biography earlier, that the health white paper has been already passed in Parliament, and it is the 15-year health reform plan, and we are focusing on evolving Malaysia to the next step in that sense. And thank you very much.
Thank you, Dr. Dinesh, for very interesting presentation. A lot of areas you have touched upon. So there are a few questions and I'll come back to you on that. So let's now
Dr. Anupama, if you don't mind, I would just like to, make few comments. I hope we have some time.
Yes, we have.
Yeah. Thank you, Dr. Dinesh. Thank you for the presentation. And also, Dr. Somil, also prior to Dr. Dinesh. Just few, when you were sharing about Malaysia, I think I must share here, about the India's current, I'm sure Dr. Madan Gopal would be touching upon it later on, but just to supplement that. Our as per National Health Policy 2017, actually, I was in when we wrote the 11th plan, I was in Planning Commission 2006 and 7. We thought that 70% of funds, so government health funds, should go to primary, and 20 to secondary and 10 to tertiary. But in National Health Policy 2017, we committed 66% of government funds, the government health expenditure, towards primary. In fact, we are very happy to see that national health account 2021-22 clearly shows that it is around 52-53%. In fact, prior to COVID, it had reached 56% in primary. That's the approach government of India is taking. And COVID, of course, we all know how it was, and there was less expenditure on primary. It was more of quarantine and isolation and all, and more on secondary and tertiary. And ideally, the government's expenditure also shifted towards that. But now it is again coming back towards the primary sector as such more, and with comprehensive primary health care, with assured linkages and out-of-pocket expenditure is decreasing tremendously. So 63-64% in 2013-14. It is now 39.4% of the total health expenditure, and the government expenditure on health, which was 28% of total health expenditure in 13-14, it has crossed 48% now in 21-22. So of course we have 7% odd, which is prepayment to the for insurance, which is both from the individuals as well as the other for family. As such, when we say expenditure is more, and this doesn't include the opportunity cost. So in future, we need to look at that also when we talk of the financing system. You mentioned about sustainable financing. Definitely, I would like to expand it further, take it further. That we also need to look at efficient and effective utilization of resources, especially a country like ours. I don't know what is condition in Malaysia, but I think a lot of other countries also. And when funds are given, how efficiently and effectively they are utilized in a timely manner as per the needs of the community. I think that's I just wanted to add on to your presentation and also share something about India, that there's an intent. There's definitely increasing funding for the health. There's a large infrastructure mission ever launched in the country, PM Abhi, which I mentioned earlier, and 15 Finance Commission grant, 120,000 odd crores over 5 years, and which is being utilized by the states as such. So thank you very much for that, for the presentation. Thank you.
Thank you, Dr. Kotwal, mentioning about the utilization and efficiency of public spending and the expenditure, health expenditures. Most discussed area when we talk about even governance. So moving to our next speaker, Dr. Madan Gopal, who is the advisor on public health administration, NHSRC, Ministry of Health, India. So it's going to talk about leadership and governance in Indian urban health. So just taking a moment to briefly introduce him and about his wide, extensive experience in health sector. So Dr. Madan Gopal is a seasonal public health professional with 30 years of transformative experience in health sector reforms and strengthening health systems across India. As a medical and MD in preventive and social medicine, he has played pivotal role in shaping policies and programs that have enhanced healthcare delivery, particularly for underserved populations. Dr. Gopal's extensive career includes spearheading health sector reforms and health system strengthening in Chhattisgarh, 2002 to 11, where he had led critical initiatives for institutional capacity building, workforce training, and strengthening primary and secondary health delivery. As senior consultant at Niti Aayog, Dr. Gopal played a pivotal role in creating and advancing the State Health Index, spearheading its development for 5 editions to drive competitive federalism and improve health system performance across state. He has successfully implemented the Rashtriya Swasthya Bima Yojana, RSBY, one of the world's largest insurance scheme, earning him the National Award for Outstanding Achievement and pioneering the CSR-driven employer-led model for healthcare initiatives targeting vulnerable populations. Currently serving as advisor, Public Health Administration at NHSRC, Ministry of Health and Family Welfare, Dr. Gopal leads state-level health governance reforms, capacity building, and evidence-based policy making. Known for his humility, collaborative leadership, and strategic insight, he remains a key architect of Indian evolving healthcare landscape. Over to you, Dr. Madan, for the presentation. Titus, do we have Dr. Madan with us?
Yes.
Okay. Yes, Dr. Madan.
Okay, thank you, Anupam. Thank you very much. Sorry, because I'm in car. I'm in a cab commuting back, commuting down. after completing the meeting, as General Kotwal has mentioned about, we were both in the same meeting, and the meeting concluded around 6:30. So thank you very much, Anupama. Good evening, good morning, and good afternoon, everybody. And I think after hearing Saumil, we used to work together in RSPY when he was in India. At that time, we used to talk about universal healthcare and universal health coverage. And in fact, working with him, we have seen that how the RSPY has shown us a way that insurance can work in the health sector and how the private partnerships can evolve in partnering with the government schemes to deliver the health services and especially the secondary and the tertiary level care. So that's another thing. But one of the important things which we should know, I would be talking about the leadership, the governance, and the challenges in urban health. My senior, General Kotwal, has already mentioned about the initiatives which the government of India is taking, and he has dwelled deeper into the various aspects, how the structure is there in the country and how things are evolving and how we are trying to address and bring models to deliver effective care. The intent is there in the form of National Health Policy 2017, wherein there is a lot of focus on reducing out-of-pocket expenses and the efforts which are being made, because NSHRC is also the secretariat for the national health accounts, and Professor Kotwal has already mentioned that how the out-of-pocket expenses and the national health accounts has mentioned about the government spending on health that has increasing and the out-of-pocket expenses increasing. But I won't be dwelling on that, but I would be just focusing myself on the challenges which we would be having in the urban sphere. That's one thing. One of the important things which Somil and other people have mentioned about the urbanization. Let us talk about few data points. India is contributing to around 18% of the world population. That means the population stands at around 1.4 billion. Is now the first country to have the largest population. So that's one other thing. Second thing is we are now housing around 480 million people in the urban areas, and most of these people, they are concentrated in 10, 11. It's around 11 states. That's there. Compounded with that, we do have a migration problem. Around 35% migration. The migration level is around 35%. You see that in the coming years, the proportion of uh, this urban to rural population would be reaching around 40%. And as things are the other challenge which has evolved during the years, where we have focused entirely on developing system which caters to the rural requirement. At that time when we were designing the system in 70s and 80s, the rural population was comprising around 80%. Now that ratio is changing, and the urbanization has evolved. The urban cities have evolved, and some of the cities, they are planned cities, some of the cities, they have evolved depending on the needs. And you can think about the challenges which pose when unplanned expansion of urban cities and other things happen. That's one of the major challenge which is there. The urban population is increasing, and to accommodate that, you are having stress on many things. That's a very important challenge which we are having. The second thing is that the as we have focused more on the rural side, to the urban system has evolved on its own. But nevertheless, they were focused on the urban areas also in it, right from in 80s, where we started the Indian population projects, which started with having some health posts in some urban area. That kind of things have evolved from 80s. But subsequently, when India became signatory to the Millennium Development Goals and as a vehicle for achieving the Millennium Development Goals, the NRHM program was launched as a mission. You see that the results, how the results were there. Looking at the vehicle and the strategy which we have adopted at that time, the primary health care strategy which we have adopted, and the vehicle which we have used, National Health Rural Mission, it has started yielding result. But nevertheless, the challenge was how to address the urban population. So as a result, what happened? There was an increasing threat for having an urban mission. We started with an urban health mission, but subsequently seeing the commonality and other thing, to have a unique, to have a unified leader. So we merged, both the programs were merged, and it was rolled out to the National Health Mission. But nevertheless, the whole objective was to address and deliver the commitments under the Millennium Development Goals, which the country has envisaged at that time. When this National Health Mission was started, there was increasing need for having a framework for the urban setting. And the framework a little bit, General Kotwal has already mentioned that how what we are having in the urban sector, right from polyclinics to arm clinics and other sectors, that network is there. Besides that, if you look at the urban settings, because the it's a mix of government and public. When the liberalization started in the country in 90s, a lot of private sector and other people come up. Now, if you look at the way the treatment opportunities which are available in the urban settings, it's a mix of public and private. Both the institutions, they have footfalls are the same, but the high-end care and the technology-driven care is more in the private sector. But looking at the things in the 2008, the RSPY program was also launched to address the secondary and tertiary care. More or less, it was focused on poor, poor population who usually are migrant or the migrant laborers. It was addressed to that, and you would be. It is very interesting to know that in India, around 93% of the working population they work in the unorganized sector, and to address the catastrophes to their illness, the health-related events, the government has started this RFZY program during that time. And this program was further expanded and scaled uh, the, for the last 1 decade, which is now known as the PMJ program, Pradhan Mantri Jan Arogya Yojana. The largest assurance scheme covering around 750 million population. And if you add to the other insurance sector or our coverage, you see like how many people are covered. The whole objective is to reduce the out-of-pocket excess so that a catastrophe due to that is avoided, and our goal for achieving the universal care is also actualized. But if you look at the opportunities and the initiatives which we are taking, you see that how the need for addressing to the urban health population, it has resulted in lot of models which are there in the country. You talk about the uh, talk about how the equitable care, how the use of telemedicine, how different models have evolved, and it's very interesting to know that all the models more or less are yielding results, and they are trying to improve the access to the services as well as providing quality of services. Nevertheless, there are other things also which are there, which needs to be there. But you have to see that what the government is doing to address the urban issues. Urban issues, as Somil has rightly mentioned, that it not only health, it's related to pollution. It talks about the other challenges in the urban, right from the pollution aspect, right from the water and solid waste management. It talks about the health and the healthcare delivery services. But if you look at the way the government is, what the government of India is doing, we do have an urban health mission which talks about strengthening the urban health infrastructure as well as providing healthcare services, assured services through the health institution which we are having. If you talk about the assurance given by the government for the arm center, which is the smallest unit in the urban area catering to 20-30,000 population, 12 services are assured apart from uh, the diagnostics and the medicines which are available free of cost in this institution. Apart from that, if you go to the polyclinics where you have the specialist care, all this care is provided free of cost in all the public institutions. That's a unique feature of this urban health mission. The other thing is, and beside the extension service in the form of immunization and the preventive services, including the family planning services. That's one another thing. Besides that, if you look at the planning which is happening at the government of India level, we started in the urban ministry has started the smart city program, wherein it talks about a holistic approach to addressing the issues in the urban area, including health. In the smart city mission, you have walking tracks, cycling tracks, as well as the open gyms and other things are there. They talk about a dashboard in the country where the disease surveillance and other things are also happening there. If you talk about the other the thing in this urban city mission, I think they are having through the dashboard, they are having the digital integration also. how the different programs are integrated together. That kind of thing is also happening. But as the scope and need was there in the urban areas, a lot of public-private partnerships have evolved, and all the models, they are unique to themselves, and they are addressing the local specific needs in that area. So that means we have the urban health mission, we have the smart city mission, we have the public-private partnerships which have evolved over the years. Besides that, if you look at the urban areas, one of the challenges that the urban areas fall under the local bodies, and the health services are being administered by the Ministry of Health or Department of Health and Family. To address this issue also, this issue is also there. So what the leadership changes which we are trying to address, we are trying to strengthen the urban health things by empowering the local bodies. In India, we do have some funding mechanism, the strengthening of the local bodies through the 15 finance mechanism or the finance commission mechanisms are there. In the 15 finance commission also, you see the largest pan infrastructure Indian mission was launched, and it's all the funds are rooted through the local body. That means to enable the local bodies which administer the urban bodies, we are trying to empower them by funding support and other things. And there is a lot of synergies which are being built between the local bodies and the district health facilities. So we are trying to see that how the intersectoral coordination, the interdepartmental coordination is there. But one of the beautiful example of this inter-sectoral coordination is that in the smart city mission, all the in all the planning process, the health department is involved. So that's the beginning where a lot of things is happening, and they are trying to bring all the data, and that data is also being fed into an integrated folder, the portal of the health ministry, so that we have the intelligence available for taking action on the disease which are of public health importance. So many things are happening, and I think the leadership and the governance related issues, slowly and slowly, all the nuts and bolts they are put into place, and all the puzzles which are there, that the silos in which previously the urban and the health department used to work, now they are all working in sync. And in the coming years, you will be seeing a lot of initiatives, lot of new models which are coming up. Nevertheless, the urban health mission would be the anchor, and it would be revolving around this urban health mission with the Ministry of Health. I will stop here. Thank you very much.
Thank you, Dr. Madan, for raising all the pertinent areas and the issues, and elaborating on the NUHC and the smart city mission, and also the role of urban local bodies, and how important it is to empower them. But still, I think we have a long way to go. So I'll come back to you on some of the questions, but we have some questions with Dr. Dinesh. Dr. Dinesh, and I think it relates because you also mentioned how the public-private partnership plays a key role. So Dr. Dinesh, you mentioned about some symbiotic dual healthcare system, public and private, very interesting. And of course, the issues of rising medical cost inflation and other issues, and some of the new initiatives like one patient, one record, and some of the digital health initiatives, and the private financing and health reforms, which is being recently passed. So can you talk a little bit about how the PPP are emerging and how it is, especially in Malaysia, when we know that the health indicators of urban poor at times are worse than the rural counterparts. So how the PPP is emerging a solution to address that? Any successful examples, if you can share with the audience? Thank you.
In terms of PPP, we have done a few work in terms of interventions in that sense. As I mentioned, Anupama, we have created a strategic purchaser, which is owned fully by the government and Ministry of Health, which could purchase services to from the private health sector. So what we've done is in 2018, once the company was established, we started off with this program called PECA B40, whereby it's a screening initiative for the bottom 40% of population. So from the initiative of screening till now, we have identified almost 40% of undiagnosed, and currently they are then referred to a health facility for further interventions at this point of time. They have I can't remember the exact number. So the exact number the screen was in the millions over the years since 2018. Secondly, as we already had the strategic purchaser, as I mentioned earlier, it was easy for us to roll out a public and private effort on the vaccination, COVID-19 vaccination. So since we already had that structure, we managed to get the grants in and push the private sector to drive up the vaccination effort. So it was like the whole sector and the whole ecosystem were working towards, and I think we had one of the highest rate of the first dose vaccination and also as well as the second dose vaccination in Malaysia. Thirdly, currently we have also moved to hospital outsourcing. As you know, there was a lot of elective surgeries and so on halted during the COVID-19. So we have already tested out a little bit on outsourcing and decanting of patients during the COVID. Now we have further improved the strategic purchasing of these services, and it has a medical audit component and so forth. And currently we have a certain grant from the government, technically for where there's a waiting time is very high for certain elective surgeries to be done in the private sector. And we also monitor their quality, and it's a negotiated amount in that sense. On what's for the future, we are looking at how do we also improve strategic purchasing within the payers of the private healthcare. Currently is all for fee for service, itemized billing, and so on. As you know, there were a few news in the papers in Malaysia. Premiums of insurance are rising, medical cost is increasing, people cannot afford care. Our aging populations who could not be covered under insurance above 60 or 70, they are having hard times accessing care in the private sector, and this falls back the burden on the government sector technically to take care of all the patients. So we are looking at interventions. How do we intervene? Not through regulation, but firstly through interventions of adjusting the PPM reforms. We're looking at such as DRGs and so on to be implemented, and also value-based paradigm. It's quite a huge what they call notion of value-based healthcare. It's quite big technically in what sense you come through. So we are finding our way in what we define it and what is exactly value-based healthcare in Malaysia in that sense. Secondly, in terms of harnessing private financing as well, what we have done is we have this challenge of attrition of our specialists and so on from the public side to the private sector because of the income gap that is quite big. The pay gap which is quite big. So we are also marginally using private financing to make some room with selective whereby a patient can choose their doctors as well as have a little bit of comfort and privacy in the public sector, whereby then they could be treated, and in a way we also could let our specialists and doctors earn more, and the rest of the health professionals earn more, as well as whatever profits and all that is made is reinvested back into the government health facilities. So that is one of the initiatives that we are doing. It doesn't take away our commitment to public healthcare services. It is still there. It's a very thin layer in that sense. So these are some of the initiatives that are ongoing. We're also looking at how to you remember the 36% out-of-pocket expenses that I've mentioned. So a large portion of it is through hospital care, almost half of it, whereby we are trying to see how do we move it to a prepaid and pool financing method with a standardized product in the private sector, as well as insurance product in the private sector, as well as how do we move the needle towards lowering down our OOP. Thank you.
Yeah, thanks, Dr. Dinesh. Yeah. Well, some of our trust hospitals in India and low-middle income country, they also do private OPDs just to generate revenue, who can pay, and then it feeds to the overall operation and the revenue of running subsidized services for the underprivileged section. So yeah, so that has been the interesting models. But in the private PPP, it's always the provider payment, which is always the pain point, and the delays in that, and that always sabotage the whole PPP model at times. So in India, we're trying to come up with the new innovative solutions to address that. But I hope in Malaysia you have a very seamless process in PPP models. We don't have issue around that. So yeah, thank you so much. Very very thought-provoking, and so if we have more questions, we'll come to you. But it's more interesting. Probably most of our audience will go and learn more about what are the health reform plan is going to do in Malaysia after this. Dr. Madan, I have a few questions with you. So you have mentioned the role of urban local bodies and how important it is to strengthen them. So it's like, what can we do to strengthen, or what are the initiatives being taken in strengthening? One, you have mentioned that urban planning, now the health is part, but at times when there are several urban local bodies also in India, and when it comes to city, they have city corporations, city councils. We have so many different, very fragmented urban governance in many ways. So how we can strengthen and highlight, or how these urban local bodies can play the role of health, or reaching the urban health goals. Can you, if you
Okay.
just
Okay,
elaborate
thank you.
on that?
Thank you, Anupama. This is very important question because in India you have a three-tier government structure. So rather to say, that means the union government, state government, and the local self governments. And these urban local bodies, they are the local self government, because if you look at the Western countries also, it's the counties, small cities which usually decide and make plans for them. And as the urbanization is happening and more or less the right kind of approach is there in the form of smart city missions and the city missions, I think the focus is on building capacities, understanding the problems of the urban areas, as well as making city level plans. In fact, at an SHRC also, we are helping the municipal corporations in coming up with city health action plans, including capacity building of the people so that they can think, hey, what to do. You take the example of the dengue across the country, because 2 3 years down the line, everybody was talking about dengue in the country. Now you see that how the local bodies, the municipal corporations, they have started a movement in conjugation with the health department. You see that what kind of mission, what kind of efforts which the local bodies are making, the municipal corporations making for uh, addressing the issues of dengue. That's one example. Second thing is, if you talk about the urban health structures which have evolved, uh, you see how the planning has built into that, and the notion that the replica of the rural areas won't work in urban areas. You see that how the new models have evolved. If you go to any urban arm center, you will find that it is led by a medical officer who would be there and taking care of that. In urban area, what the common man wants, he wants to be seen by a medical officer. He wants that he needs to be tested. He wants the free medicines. All the three things are available in the urban arms and the urban center, which has evolved over the last many years. Second thing, once it comes to the planning and building capacity, you see that the government has always emphasized on building capacities of the urban local bodies. You see a lot of tailor-made training programs are there. There are many institutes which are doing the State Institute of Rural Development, as well as urban local bodies. Institutes are training institutes are there who are investing a lot into building capacities, not only on the but the elected representatives in these urban local bodies. We are trying to focus on them so that they are capacitated in understanding the needs of the community, as well as contribute to the planning of this. Secondly, you look at the way things are happening. every ward member is now empowered. They usually create, uh, as we have created the Arogya Samitis, the ward level Samitis are also being conceptualized, and they usually increasingly take part into the planning of the health of that particular ward. Had it not been this kind of approach during the COVID times, you might have seen a lot of catastrophe in the country. But these kind of mechanisms they have built in, and you have seen how they have collectively, along with the health department and the municipal department, how this kind of setup and this kind of capacities have yielded results. So otherwise, managing a slum in Mumbai would have been very, very difficult. It would have been a humongous task. But nevertheless, your question was that what we are doing for planning and building. There's a the government is mindful at the highest level that the urban area and the urban health needs the priority. The urban health mission is there. That's another commitment from the government side. We are we are very conscious about the needs of the urban population. The other thing is the including discussions on and discussion and discourse on the urban health requirements, be it pollution, be it sound pollution, noise pollution, water pollution, as well as the other requirements. Because in the traffic intersection also, you have to see that it starts from that. I'm just citing an example. Now people are increasingly thinking about bringing planning into that kind of cycle. In fact, the urban health framework, which the NSHRC has developed, it talks about the addressing the social needs of this kind of areas also. We have included that thing, and we see that once the framework is already there in the public domain, but once it is been adopted by all the ministries, we have sent it to the Ministry of Urban Affairs. If it is adopted, that you will see a lot of changes which are happening. Already changes have started happening, but you will see a lot of changes, lot of impetus would be there in the work which we are doing. I think I've been able to answer your question.
Yes, yes. Thank you, Dr. Madan. Yeah. Well, Dr. Kotwal already mentioned about what are the new initiatives of setting up a sub-center and under urban health and urban health mission and polyclinics and improving the referral pathways, which is still, we have a long way to go. And the definition of acceptable health is still evolving. What exactly does it mean? And so we have discussed about intersectoral coordination, which falls under the ULBs and the other sectors within the urban health, which becomes more and more important. I think we are almost at the closure of our webinar. So I'll ask Dr. Kotwal to share the closing remarks, and I'll just wrap up after that.
Thank you, Dr. Anuma. I must thank all the presenters, speakers for the excellent the presentations. And also thanks, Dr. Anuma, for those questions which, elicited responses from the speakers and they elaborated few of the points. So the few, I think, for uh, take home message, I think, for way forward as such that, we need to have some kind of different approach for the urban health as such. If you're thinking of achieving universal health coverage, the what kind of incentives again we need for the healthcare team, which we are looking at in the rural and how different could be from the rural areas. Challenges not only for the health, but also social determinants of health, which would be very, very difficult to, address in the urban slums and certain areas and all. What kind of approaches are required? Intersectoral coordination is another thing with various agencies involved in urban area. And also beyond health, the social determinants and all, when we talk the pollution, the air pollution and all the other aspects, what is their impact on especially the non-communicable diseases which are increasing now. At the same time, there are pockets in the urban areas where communicable diseases are still, continuing as such, and not only the waterborne, also even vector-borne. So how to address those as such in a unified way. The I would like to share something here of my personal this thing view that although we talk about even in the this thing we may mention, we give tell the states that okay, the urban arm or urban sub centers have been created, give priority to the urban slums and all. But something it is there that if you create health facilities for the urban poor, it will lead to facilities being made poorly as such or working poorly. So I think we should now have a focus on creating health facilities where the urban middle class starts, utilizing those. That should be the approach. Of course, we need more finances for that, and a different kind of approach. So how to look at that? How to the opportunities which are there, how to utilize those? The funding as such, as far as my India is concerned, it is available. But again, a large part of these funds which are allocated every year are not being utilized even in the Finance Commission and all. So that's what I think we need to look at, how to effectively and efficiently utilize those funds, how we can work with the states, and I think same will goes to the several other countries too, to the local bodies and all, where it has been decentralization has been done, to prepare the DPRs and all, and how to have efficient construction. Human resources again, urban areas, of course, a lot of people are ready to join the health services, but to retain them, they may initially join, but again, there are a lot of other opportunities in private and other facilities. So they are likely to we're likely to lose them after a few couple of months or couple of years. So whatever you spend on them on capacity building and initial retention as such. So for that retention, our governance and administration, that also needs to effectively be improve as such, if we want to improve our urban health facilities, and the urban ashas and all, where we know that Mahila Arogya Samitis and urban ashas, the community processes which are there in urban areas, they will not be effective for the gated communities as such. How to at least to start making them more effective in the urban slums, and then what kind of interventions do we need to get the middle classes in the gated communities and all, for their community processes. Because if we start assessing even there, the knowledge about the health seeking practices or health behaviors and all is not that great as such. There are studies available, small studies available, for those people. So we need some kind of interventions for them too. RWAs has been tried and tested, but then not that effective as such. But how to increase their involvement in this in the urban health? So I think few of these have been answered, but I think we need to probably follow up with this subsequently. And I would request all the experts who presented, if they can share their views on these also subsequently, in some bullet form and all, and we can have further discussions on this, and we can work with you, come up with certain suggestions to look at even specific metropolitan area specific, or even general common urban area approaches as such. The guidelines for urban area as such are in a draft stage, of course, an advanced draft stage, but we'd be very happy to get your suggestions to add something to that if we have not included that. So we will be very happy to receive your inputs for anything new approach in the urban healthcare, starting knowing from your on-ground experience and vast experience which you have in your areas of work as such. Thank you very much for this opportunity to be able to listen to all of you and interact with you all. Thank you. Over to you, Dr. Anupama.
Thank you, Dr. Kotwal. Yes, I'll also personally keep in mind that you have to dig deeper to get the things. Doesn't seem what it seems on face, and things are very different when you start looking at the details and at the minor portions of it. And I think Somil's presentation was apt on it, where he showed how the quintiles are moving. So urban poor, or the urban poor urban health indicators might not be adverse, what it seems has been mostly talked about in the literature. It all depends upon which indicator and what level and what quintiles level we are talking about. So thank you so much. I thank all the speakers. And as we conclude, there will be a blog, and there will be the recordings, and it will be shared with all the registered participants. And I thank our audience for listening to us, bearing with us. And I hope in future we again have such kind of more series, and we look forward to have the contribution of speakers in the on the urban health side, which Dr. Kotwal mentioned. Thank you so much for your time and being here and sharing your experiences. Thank you so much. Have a lovely evening and a day. Thank you.